Imagine a patient wheeled into your ICU. Moments ago, they might have seemed mostly functional, but now they're fighting for every breath, their muscles failing rapidly, leading to sudden, life-threatening respiratory collapse. You're looking for a primary lung issue, but what if the problem isn't in the lungs at all, but at the very intersection of nerves and muscles? This, for you, the critical care intensivist, is the stark reality of myasthenia gravis, or MG.
It's a profound and often bewildering presentation because the core issue is systemic.
Yeah,
Yet its most acute manifestation can be purely respiratory, and that demands immediate and precise intervention from specialists like us.
that's right. Today, we're embarking on a deep dive into myasthenia gravis, specifically tailored for your world, the critical care intensivist's realm. This isn't just about understanding a relatively rare disease, it's about mastering its acute presentations, optimizing the delicate perioperative care, anticipating and treating those terrifying life-threatening crises, and, well, navigating the complexities of its evolving long-term management. Our mission here is really to distill crucial insights from the most recent guidelines and clinical reviews, equipping you with most current board exam caliber knowledge.
We truly want to ensure you're not just well-informed, but expertly prepared for the next MG patient who enters your ICU. We'll start by truly understanding MG's clinical spectrum and how it's meticulously classified, carefully differentiating it from other neuromuscular disorders that might, mimic its presentation.
From there, we'll shift our focus directly to the critical domain of myasthenic crisis and the nuanced considerations for MG patients in that high-stakes perioperative setting. Following that, we'll unpack the intricate landscape of chronic immunotherapy, including both the established agents you're familiar with and the cutting-edge, novel treatments that are really revolutionizing care.
Finally, we'll touch on special populations like pregnant patients and emerging experimental therapies. This ensures you have a holistic view of managing this incredibly challenging yet ultimately treatable condition. Let's begin.
Okay. To truly master myasthenia gravis, we first need a solid grasp of its fundamental mechanisms. What exactly defines MG at its core? What's the foundational pathophysiology we, as intensivists, need to grasp?
At its very essence, MG is an autoimmune neuromuscular disorder. This means the body's own immune system, which is designed to protect us, mistakenly turns against and attacks its healthy components. More specifically, this is an antibody-mediated immunologic assault. Imagine your body's defense system launching a highly specific, friendly fire attack against its own tissues.
And where does this attack actually happen? And what's the detailed mechanism behind it that disrupts muscle function?
So the primary targets of this misguided attack are proteins located on the postsynaptic membrane of the neuromuscular junction, or NMJ. Think of the NMJ as the critical communication bridge between your nerve and your muscle, right? Where electrical signals are converted into muscle contractions. The most common targets are acetylcholine receptors, or AChR, which are crucial for receiving nerve impulses. However, in some cases, other receptor-associated proteins are attacked, like MuSK or LRP4. When these autoantibodies bind to the AChR or associated proteins, they critically disrupt the efficient transmission of nerve impulses to the muscles. This can happen in a few ways. The antibodies can block the receptor, destroy it, or even, accelerate its breakdown.
Okay, so they interfere with the signal, basically.
Exactly. This interference means the signal from the nerve can't properly activate the muscle, leading to weakness. This particular disruption makes myasthenia gravis the most prevalent disorder affecting neuromuscular transmission, a key point for any intensivist to recognize.
So if the signal isn't getting through clearly from the nerve to the muscle, what's the direct clinical consequence that we're going to observe? How does it specifically manifest?
Right. This disruption leads to the hallmark feature of MG fluctuating motor weakness. It's not a constant, unyielding weakness, but one that waxes and wanes, characteristically worsening with sustained or repetitive activity and significantly improving with rest. This fatigability is a diagnostic cornerstone. The weakness can involve, really, any combination of ocular, bulbar, limb, and or respiratory muscles.
Let's start with ocular MG, which presents in about 50% of cases and often serves as the gateway presentation. For an intensivist, what's the classic diagnostic triad that should immediately raise our suspicion?
Yeah, the classic diagnostic triad suggesting ocular MG, or OMG, is ptosis that's drooping eyelids, often asymmetrical and fluctuating, ophthalmoparesis, which is weakness of eye movements, leading to double vision or diplopia, and orbicularis oculi weakness. That means difficulty closing the eye, particularly against resistance. You try to hold their eyes shut while they try to open them. When you observe these three together, MG should instantly spring to mind.
What makes the extraocular muscles uniquely vulnerable to this autoimmune attack? There's a specific pathophysiology there beyond just the general immune assault.
There is, and it's quite fascinating and clinically relevant. The extraocular muscles and levator muscles responsible for eye movement and lid elevation have unique physiological vulnerabilities. Their junctional folds of muscle end plates, those intricate invaginations on the muscle side of the NMJ where receptors are densely packed, are notably sparse. This structural difference leads to a lower safety factor for neuromuscular transmission in these muscles. Imagine a less robust communication line. It makes them inherently more susceptible to the impact of antibody attack.
Okay, so less reserve, basically.
Precisely, less reserve. Furthermore, complement regulatory genes are expressed differently in these extraocular muscles. These genes typically produce proteins that protect cells from complement-mediated immune damage. Their altered expression can potentially reduce the protective mechanisms against complement-mediated tissue injury, which is a key part of the immune attack in MG, further predisposing these specific muscles to early and severe involvement.
That's a critical detail for understanding the selective nature of the disease's initial presentation. What other clinical nuances should we be aware of with ocular MG?
Well, isolated ptosis and ophthalmoparesis are also very common initial presentations, even without all three triad components being simultaneously obvious. And here's a crucial clinical pearl that can differentiate MG from other causes of diplopia or persis. Pupillary function is always spared in MG. If you observe pupillary involvement, you should immediately think of other neurological conditions, like brainstem lesions or third nerve palsy.
That's a huge diagnostic clue.
It really is. It's also important to note that while highly specific, AChR ab testing in isolated ocular MG can have a sensitivity as low as 45 to 60%. This means a negative test doesn't rule out the diagnosis, making clinical suspicion and other diagnostic tests like electrophysiology absolutely vital. That said, its specificity is 100%. A positive test is a true positive.
Moving beyond the eyes, bulbar symptoms occur in about 15% of cases and represent a significant red flag due to the profound aspiration risk for these patients. What specific manifestations should we diligently look for, particularly in the ICU setting?
Right. Bulbar symptoms involve the muscles of speech and swallowing absolutely critical functions for airway protection. This manifests as dysphagia, or difficulty swallowing, which can range from mild to severe, dysarthria, or slurred speech, often worsening with prolonged talking, nasal speech indicating palatal weakness causing air to escape through the nose during phonation, or speech that's low in intensity, indicating overall weakness of the vocal cords and respiratory muscles used for speech. The patient's voice may sound weak and monotone.
I recall a very specific clinical pearl about chewing, particularly with certain foods, that's highly indicative of bulbar involvement. Can you elaborate on that? And what else might we observe around jaw weakness?
Absolutely. A classic and often overlooked sign is fatigue with prolonged chewing, like at the end of a meal, especially when the patient is attempting to eat challenging, tough foods such as steak. The masticatory muscles fatigue rapidly. Patients might even resort to using their fingers under their jaw to help keep their mouth shut if their jaw closure muscles are significantly involved. They're physically supporting their mandible because they can't maintain the closure themselves. This effort to manually assist chewing is a powerful and very specific clue to myasthenic bulbar weakness.
Wow, that's quite a visual.
It really is. And nasal regurgitation of liquids due to palatal weakness is another clear and immediate sign of significant bulbar involvement and a high aspiration risk.
And what are the critical implications of these bulbar symptoms for us in the ICU? What's the direct pathway to myasthenic crisis that we need to anticipate?
Severe dysphagia with an imminent aspiration risk is a direct pathway to what we call myasthenic crisis. Aspiration of food or secretions can quickly lead to aspiration pneumonia, further complicating the patient's respiratory status and precipitating or worsening respiratory failure. These patients often become NPO and require alternative nutritional support to prevent this.
How about limb weakness? It's less common as an initial isolated presentation, occurring in less than 5% of cases. But when it does appear, what's its characteristic pattern? How does it differentiate from other neuromuscular issues?
Limb weakness in MG typically involves a proximal predominance. This means muscles closer to the body's core, like the shoulders, making it hard to raise arms overhead, and hips, causing difficulty climbing stairs or standing from a chair, are weaker than those further out, such as the hands and feet. This pattern is crucial for differentiation.
We frequently need to differentiate this proximal limb weakness from general myopathies, which also present with proximal weakness. What are the key distinctions that can help us in an acute setting?
This is a crucial differential diagnosis in the ICU. In MG, ocular findings, such as ptosis or diplopia, are usually present, and symptoms characteristically fluctuate, worsening with exertion and improving with rest. Also, creatine kinase or CK levels are typically normal or only mildly elevated.
Okay, so normal CK and fluctuation are key for MG.
Exactly. In contrast with a myopathy, ocular findings are relatively absent. Symptoms do not fluctuate. They tend to be constant or progressively worsening, but not with the day-to-day or hour-to-hour variability of MG. CK levels are often significantly elevated, especially in inflammatory myopathies, where you might also find myositis-specific antibodies.
Are there electrophysiological differences that can definitively help us distinguish between them?
Yes, electrodiagnostic studies are key. Repetitive nerve stimulation testing, a common diagnostic tool, is abnormal in MG, typically showing a decremental response, a progressive reduction in the amplitude of muscle action potentials with repetitive stimulation. But it is normal in myopathy. Conversely, needle electromyography, or EMG, in myopathy shows specific patterns like short duration, low amplitude, polyphasic motor unit potentials, sometimes with abnormal spontaneous activity like fibrillations or positive sharp waves. This is distinctly different from the often normal or subtle findings in MG.
Finally, let's talk about respiratory muscle weakness. It's rare as an isolated presentation, but it's truly the silent threat that can escalate rapidly to crisis. How does it initially present, and what's its critical significance for intensivists?
Patients may initially present with subtle symptoms like shortness of breath or dyspnea, particularly on exertion, or difficulty taking a deep breath. However, the critical significance, especially for intensivists, is that this can escalate rapidly to life-threatening neuromuscular respiratory failure. It often marks the onset or progression of a myasthenic crisis. This weakness can be insidious, with patients compensating by increasing their respiratory rate or using accessory muscles until they suddenly can't compensate anymore, and that leads to acute respiratory failure.
Let's transition to how we classify myasthenia gravis and its epidemiology. Understanding antibody status, age of onset, and associated conditions is vital for tailoring our approach. First, antibody status. How does this specifically guide both diagnosis and treatment selection?
Antibody status is paramount in MG, guiding both diagnosis and often dictating treatment choices. Acetylcholine receptor, or AChR, antibodies are the most common, found in over 85% of generalized MG cases. They serve as our primary diagnostic biomarker. The presence of these antibodies confirms the autoimmune nature and helps direct therapy.
But there are other important antibodies, right? MuSK, for instance. What's distinct about MuSK-positive MG, both in presentation and therapeutic response?
Yes, muscle-specific tyrosine kinase, or MuSK antibodies, define a distinct and important subtype of MG. MuSK-positive MG often presents with a marked female predominance, over 70% in reviewed studies, and a typically younger mean age of onset, around 36 to 38 years. Clinically, what's crucial for us to note is that MuSK-positive MG is frequently associated with pronounced and often severe bulbar symptoms, severe oropharyngeal and facial weakness, and significantly, a higher risk of myasthenic crisis.
Higher crisis risk, okay.
Yeah. Interestingly, demographic studies suggest African Americans may have slightly higher rates of MG incidence and prevalence, with 28% to 47% of MuSK antibody-positive patients in the United States being African American. It also occurs in a higher proportion of those of Asian ancestry compared to European or African ancestry. Furthermore, and this is a critical therapeutic distinction, patients with MuSK-positive disease are generally poorly responsive to anticholinesterase agents like pyristimidine. And importantly for long-term planning, they have not been shown to benefit from thymectomy, unlike ACH-positive patients.
That's a huge difference in management. Are there other, less common antibodies we should be aware of? And what about cases where we strongly suspect MG but can't find any antibodies, so-called seronegative MG?
We also have lipoprotein-related protein 4, or LRP4, antibodies, though they're less common, found in about 2–10% of patients without AChR or MuSK antibodies. Then there's seronegative MG, where patients have confirmed disease by electrophysiologic testing, demonstrating classic decremental responses on repetitive nerve stimulation, but no measurable antibodies for AChR, MuSK, or LRP4. This form is often associated with frequent ocular MG, which we discussed earlier, due to the lower sensitivity of antibody testing in isolated ocular disease. Like we mentioned, the sensitivity of ACO-AB testing in isolated ocular MG can be quite low, 45 to 60%, making this diagnosis challenging, but the specificity remains 100%.
How does age of onset and sex predominance factor into our understanding and approach? There's a characteristic bimodal pattern, correct?
Precisely. MG can occur at any age, but it typically shows a bimodal distribution in the general population. We observe an early peak in the second and third decades, typically between ages 20-30, with a clear female predominance, approximately a 3.1 female-to-male ratio. This early onset form is often associated with a hyperplastic thymus, meaning an enlarged or overactive thymus gland, which frequently contains germinal centers.
Germinal centers like antibody factories.
Essentially, yes. These are specific sites within the thymus where robust B-cell responses against the AChR develop, acting as factories for the pathogenic antibodies. This subgroup is also associated with specific genetic markers, particularly the MHC haplotype HLA-B8-DR3DQ2, indicating a genetic predisposition.
And what about the later peak in presentation?
The late peak occurs in the 6th to 8th decades, typically after age 50, often around 60-70 years, with a male predominance. These individuals more often have a normal or atrophic thymus, meaning the thymus gland has shrunk or is not active in the same way as in younger patients. This late-onset MG is associated with different genetic markers, specifically HLA-DRB115.01. Frequent bulbar symptoms are also noted in this older male group, making them particularly vulnerable to aspiration and respiratory compromise.
What about juvenile MG? What's its incidence and prognosis?
Juvenile MG accounts for about 10 to 15% of all MG cases in North America. A Norwegian study found an incidence rate of 1.6 per million children, also with a female predominance, especially in prepubertal children. Interestingly, white children with prepubertal onset tend to have the best prognosis, with a significant 44% spontaneous remission rate and a good response to early thymectomy. This contrasts, as we noted, with MuSK-positive children who haven't shown benefit from thymectomy.
Let's talk about the thymoma association, a crucial comorbidity for intensivists to recognize as it impacts management beyond just the MG. What's the prevalence, demographics, and key risk factors?
Right. Thymoma, a tumor of the thymus gland, occurs in approximately 20% of individuals with AChR-positive MG. It's important to remember this association, as identifying a thymoma warrants surgical removal. It's equally common in men and women with MG. The risk for thymoma is highest if myasthenic symptoms begin in the 4th to 6th decade of life, typically between ages 40 and 60. The risk is quite low if onset is before 20 or after 70 years of age. Thymomas in MG patients are often associated with cortical thymoma, specifically classified as type B, which carries specific histological characteristics. This underscores the need for imaging the thymus in most AChR-positive MG patients.
Quantifying severity is key for treatment decisions and prognostication in the ICU. Can you explain the Myasthenia Gravis Foundation of America, or MGFA, clinical classification, and also the MG composite scale? How do we use these to assess our patients?
Okay, the MGFA clinical classification, also known as the Modified Osman Scale, is a widely used system that categorizes weakness based on muscle group involvement and severity. It gives us a standardized way to talk about functional status. Class 1. Only ocular muscles involved. Everything else is normal strength. Class 2. Mild weakness affecting non-ocular muscles. Ocular weakness might still be there, it's subdivided. ILI, mostly limb or axial trunk muscles affected. IIUP, mostly oropharyngeal or respiratory muscles. This signals higher risk due to bulbar involvement. Class 3, moderate weakness in non-ocular muscles, also subdivided. IRLA, mainly limbaxial. IOIAB, mainly oropharyngeal respiratory. Class 4, severe weakness in non-ocular muscles. IV, limbaxial predominant. IV, oropharyngeal respiratory predominant. Class V, this is the most critical for us intensivists. It's specifically defined by the need for intubation with or without mechanical ventilation. This excludes routine post-op management. And importantly, a patient with a feeding tube but without intubation would be Class IV, severe bulbar issues, but not yet needing intubation for respiratory failure.
Got it. And the class is based on the worst affected muscle group.
Exactly. Always assessed according to the most severely affected muscle or muscle group.
And what about the MG composite scale? How does it provide a more nuanced assessment?
The MG Composite Scale offers a more detailed quantitative assessment, often used in clinical trials, and for precise tracking in practice. It combines both patient-reported symptoms and bedside examination findings across 10 distinct domains to define overall severity. These domains check everything from eye movement and speech to swallowing and limb strength. For this scale, moderate weakness is specifically categorized as 50% of normal strength, plus or minus about 15%. Anything less severe is mild, anything more severe is severe. This allows for a much more granular and objective tracking of improvement or worsening over time, which is invaluable for assessing treatment response.
And for us on the front lines, a manual muscle testing worksheet is a practical tool for objective, repeatable assessment. What specific muscle groups are typically included in such a worksheet to aid in precise documentation of strength?
That's an excellent point, especially in the ICU when tracking subtle changes. An MMT worksheet helps us objectively document and track strength changes. It includes specific assessments like lidiposis, measuring eyelid droop, diplopia, assessing double vision, eye closure against resistance, cheek puff, checking facial bulbar strength, tongue protrusion, jaw closure, neck flexion and extension. Then shoulder abduction, elbow flexion extension, wrist extension, grip strength, hip flexion, knee extension flexion, and ankle dorsiflexion. This level of detail aids in precise point-in-time documentation, typically graded on a scale from 0 for normal strength to 5 for severe weakness or paralysis.
Okay, let's just take a moment for a brief pause and lock in some of these initial concepts. We've defined myasthenia gravis as an autoimmune, antibody-mediated attack at the neuromuscular junction, causing that fluctuating muscle weakness that worsens with activity. We've parsed how this manifests variably as ocular, bulbar with that crucial aspiration risk limb, and critically respiratory weakness, always with that telltale fatigability. We covered the different antibody types, AChR, MuSK, LRP4, and seronegative Mg, and how their presence or absence can significantly guide our diagnostic and therapeutic approach. We also touched upon the bimodal age of onset and the importance of specific classification scales. This groundwork is vital for what's to come. So for a quick board-style question to test our understanding, you have a patient presenting with acute severe proximal limb weakness and significantly elevated creatine kinase levels. They deny any history of ocular symptoms, and their weakness does not fluctuate throughout the day. Repetitive nerve stimulation testing is normal, and needle EMG shows short duration, low amplitude, polyphasic motor unit potentials.
Is this myasthenia gravis, and what are the key reasons for your conclusion?
No, this clinical picture is highly unlikely to be myasthenia gravis. The key differentiating factors here are the significantly elevated creatine kinase, the absence of fluctuating symptoms, which is the hallmark of MG, the normal repetitive nerve stimulation testing, and the specific EMG findings of short duration, low amplitude, polyphasic motor unit potentials. These findings are classic for a primary myopathy, not MG, where you'd expect normal CK, fluctuating weakness, and a decremental response on repetitive nerve stimulation. This distinction is paramount in the ICU for guiding further workup and acute management.
That's a perfect clarification. Now, given the varied and often overlapping clinical presentations, distinguishing MG from other neuromuscular disorders, especially in an acute setting, is vital for intensivists. Let's delve into differential diagnosis. What else should be on our radar when we specifically encounter acute ocular weakness?
Right. Beyond MG, ocular weakness can stem from several conditions. You must consider brainstem lesions and other cranial nerve lesions, which can present with ptosis or ophthalmoparesis, often with associated neurological deficits. Horner syndrome, a disruption of sympathetic innervation, can cause unilateral toposis, miosis, and anhidrosis. Thyroid ophthalmopathy, particularly Graves' ophthalmopathy, can cause restrictive eye muscle disease, leading to diplopia and proptosis. Oculopharyngeal muscular dystrophy is a genetic condition causing late-onset ptosis and dysphagia. Finally, chronic external ophthalmoplegia, which is often associated with mitochondrial diseases like Kearns-Sayre syndrome, can cause progressive weakness of extraocular muscles. Differentiating these from MG is key because, as we highlighted, pupillary function is always spared in MG. Myotonic dystrophy also presents with ptosis and ophthalmoparesis, alongside other systemic features like cataracts and cardiac conduction defects, so a broader systemic view is always important.
And if it's bulbar weakness that brings the patient to the ICU, what are the critical lookalikes that we need to rule out?
For acute bulbar weakness, you need to consider a range of conditions. These include brainstem and multiple cranial nerve lesions, such as those caused by stroke or tumors, which can affect the cranial nerves controlling speech and swallowing. Motor neuron disease, like amyotrophic lateral sclerosis, ALS, can present with progressive bulbar weakness, though typically without the fluctuations seen in MG. We must also consider obstructive or malignant lesions of the nasal and oropharynx that could mechanically impede speech or swallowing, such as a large tumor causing mechanical obstruction or nerve compression. Botulism, an intoxication from botulinum neurotoxin, can also cause acute flaccid paralysis with prominent bulbar symptoms due to presynaptic blockade of acetylcholine release.
How about generalized limb weakness, particularly when it's acute and severe? That's a broad category with many potential culprits beyond MG.
Indeed, for acute limb weakness, the differentials expand significantly. We must consider other motor neuron diseases, although they typically have a slower, progressive course. Acute inflammatory demyelinating polyneuropathy, ADP, of which Guillain-Barré syndrome, GBS, is the most common form, presents with rapidly progressive ascending paralysis, often with antecedent infection. Other motor neuropathies, such as multifocal motor neuropathy, also need to be considered. Multiple radiculopathies affecting nerve roots can cause weakness in a specific distribution. Lambert-Eaton myasthenic syndrome, or LEMS, is a crucial one to distinguish. It's also a presynaptic autoimmune disorder of the NMJ, but causes increased muscle strength with repetitive effort, in contrast to MG's fatigability.
The opposite of MG's fatigue.
Exactly. And of course, various types of myopathies, whether inflammatory, toxic, or metabolic, as we discussed earlier, will cause proximal limb weakness.
Let's reemphasize the myopathy versus MG distinction again, as it's so important and often presents a diagnostic challenge in the acute setting.
It's vital for us to differentiate. As a reminder, myopathy typically features proximal limb weakness, but with a relative absence of ocular findings. Crucially, myopathy symptoms do not fluctuate. They tend to be constant or progressively worsening, unlike the characteristic fatigability of MG. You'll often see an elevated creatine kinase, sometimes significantly, and in autoimmune or inflammatory myopathies, the presence of myositis-specific antibodies can confirm the diagnosis. Electrophysiologically repetitive nerve stimulation testing is normal in myopathy, while needle electromyography shows those specific short-duration, low-amplitude, polyphasic motor unit potentials, often with spontaneous activity like fibrillations, which are absent in MG.
And finally, when we're faced with acute neuromuscular respiratory failure in the ICU, what are the less common but critical causes beyond MG that we should consider, especially when the diagnosis isn't immediately clear?
Beyond myasthenia gravis, which is a key cause, other less common but critical causes of acute neuromuscular respiratory failure include conditions like Guillain-Barré syndrome, GBS, and other forms of chronic inflammatory demyelinating polyneuropathy, CIDP, which can cause severe ascending paralysis impacting respiratory muscles. Severe rhabdomyolysis can lead to profound muscle weakness, including respiratory muscle failure due to extensive muscle breakdown. Botulism, as mentioned, can cause descending paralysis and bulbar symptoms that compromise the airway. Certain brainstem strokes, particularly those affecting the medulla, can directly impair respiratory drive and cranial nerve function. And various types of severe myopathy can also progress to respiratory muscle weakness. It's also worth noting that in about 5 to 10% of patients presenting with acute neuromuscular respiratory failure without a known neuromuscular disease on admission, the precise cause might initially remain undetermined, necessitating a broad diagnostic approach.
Moving on to associated comorbidities and additions. It's clear that myasthenia gravis is rarely an isolated disease. It often exists within a broader context of immune dysregulation. As intensivists, what should we be looking for beyond the immediate MG symptoms?
Exactly. A broader view is essential. For instance, any patient suspected of having MG, not just those with clear thymoma signs, should undergo chest CT or MRI to evaluate for thymic abnormalities, given the strong association with thymoma in AChR-positive MG. Beyond that, we must be acutely alert for clinical features that may suggest comorbid autoimmune conditions. These necessitate additional serologic tests beyond the MG antibodies, such as thyroid-stimulating immunoglobulin, antithyroid peroxidase, antithyroglobulin for thyroid disease, or rheumatoid factor for rheumatoid arthritis.
And the sources list quite a few associated autoimmune conditions, really painting a picture of MG as part of a larger systemic immune dysregulation. Can you run through some of the key ones that an intensivist might encounter or need to be aware of?
Yes, the list is indeed extensive, highlighting the systemic nature of autoimmune disease. In the neurological realm, you might encounter coexisting polymyositis, a sensory neuropathy, stiff person syndrome, neuromyelitis optica, Isaac syndrome, or neuromyotonia, Lambert-Eaton myasthenic syndrome, and even rarer conditions like hemichoria. Hematologic associations can include pure red cell aplasia, agranulocytosis, hemolytic anemia, and pernicious anemia. Dermatologic conditions sometimes involve alopecia areata, pemphigus, scleroderma, oral lichen planus, and vitiligo. Endocrine links include Addison's disease, Cushing's syndrome, panhypopituitarism, and various forms of thyroiditis like Hashimoto's or Graves' disease. And then there's a miscellaneous category with conditions like acquired hypogammaglobulinemia, myocarditis, nephrotic syndrome, rheumatoid arthritis, sarcoidosis, hepatitis, gastrointestinal pseudoobstruction, and ulcerative colitis. This broad spectrum means we need to maintain a high index of suspicion for concurrent autoimmune processes, as they can significantly impact overall patient management and prognosis.
That's a comprehensive overview, highlighting why a holistic approach to these patients is crucial. Now let's pivot to Chapter 2, which is often where we, as intensivists, first encounter these patients in their most vulnerable state. Acute myasthenic crisis and perioperative management navigating high-stakes scenarios.
This chapter is truly at the heart of critical care for MG patients. Yeah.
Let's start with myasthenic crisis itself, truly the ultimate test of intensive care. How do we precisely define it? And what are the typical triggers that we need to be vigilant for in our patients?
A myasthenic crisis is unequivocally defined as a life-threatening neuromuscular respiratory failure. It's a medical emergency requiring immediate intervention. The most common trigger we see is concurrent infection, particularly respiratory infections, which can dramatically increase muscle fatigability and precipitate decompensation.
Makes sense. Infection is often the tipping point.
Absolutely. However, it can also be triggered by surgery, pregnancy, childbirth, or even certain medications, and we'll delve into a critical list of those soon. Sometimes it occurs during the tapering of immunotherapeutic medications, or it can spontaneously rise as part of the natural history of the disease without an identifiable exogenous trigger.
Are there warning signs or subtle clinical clues that we can look for before full-blown respiratory failure hits, allowing us to intervene earlier?
Often, patients will experience increasing generalized weakness as a warning, making it harder to perform daily activities. However, and this is critical for intensivists, occasionally the respiratory insufficiency can be out of proportion to their limb or bulbar weakness. This means a patient might still appear relatively strong in their limbs, but is already on the brink of respiratory collapse. Early recognition is particularly challenging in these scenarios. You must also be vigilant for signs of bulbar weakness, like increased difficulty swallowing or managing secretions, as aspiration often precedes or complicates respiratory failure.
So what are those subtle early signs of respiratory failure progression that an intensivist must spot, perhaps even before overt distress?
The very first and often subtle sign of impending crisis may be an increase in respiratory rate coupled with shallower tidal volume breaths, indicating increased work of breathing. You might observe the subtle use of accessory muscles of respiration, like the sternocleidomastoids or paradoxical movement of the abdomen, where the abdomen moves inward instead of outward during inspiration, indicating diaphragmatic weakness. This can even be seen in patients who are already intubated but struggling against the ventilator.
Okay, so watch the breathing pattern closely. What about blood gases?
Right. When we look at blood gases, spontaneously breathing patients may initially show hypocapnia or low CO2 as they hyperventilate to compensate. But a definitive and ominous sign of impending respiratory failure, indicating ventilatory fatigue and impending collapse, is an increase in the partial pressure of carbon dioxide, or PCO2. This is a clear signal for immediate ventilatory support.
And that severe bulbar weakness and dysphagia we discussed earlier, how does that specifically complicate things during a myasthenic crisis? What are the immediate risks?
Severe bulbar weakness often leads to significant dysphagia, resulting in the inability to manage oral secretions and an increased risk of aspiration. This aspiration of food, liquid, or oral secretions can quickly lead to aspiration pneumonia, which then acts as a secondary yet equally devastating contributor to their critical respiratory state, creating a vicious cycle. Preventing aspiration by instituting NPO status and considering early intubation for airway protection is paramount in these patients.
Given these dire consequences, what's the core management principle for an acute myasthenic crisis, and what are the first-line pharmacologic interventions?
For patients with moderate or severe newly onset MG who require a rapid and decisive response, short-term immunomodulators are the absolute first-line treatments. This primarily means intravenous immunoglobulin, or IVG, and plasma exchange, or PLEX. These rapid-acting therapies should always be considered and often initiated together with corticosteroids. They are the immediate go-to interventions for acute exacerbations and myasthenic crisis, designed to quickly reduce the pathogenic antibodies and stabilize the patient.
Let's move to perioperative management in MG. This is a detailed anesthetic blueprint, but it's critical for intensivists as we often manage these patients pre- and post-op. What's the key information we absolutely need to gather during preoperative assessment to mitigate risk and prepare for potential complications?
Preoperative assessment is paramount for any MG patient undergoing surgery, even for non-MG related procedures. You need to gather detailed information on the presence and severity of bulbar symptoms like dysphagia, dysarthria, nasal speech, or low-intensity speech, as these predispose the patient to aspiration and can indicate a higher risk of postoperative respiratory complications. A clear history of any prior myasthenic crisis and any past need for endotracheal intubation is essential, as this flags them as high-risk patients. We also need to meticulously assess for any baseline respiratory muscle weakness, shortness of breath, and dyspnea, even if seemingly mild, through pulmonary function tests if possible.
And what about their current MG therapy? How does that impact our preoperative planning?
A detailed review of their current MG therapy is crucial. We need to know specifically the type and dose of anticholinesterase agents they're on, such as pyridostigmine, as these can interact with anesthetic agents. Equally important is understanding their glucocorticoid regimen, including dose and duration, as this impacts adrenal function and surgical stress response. Finally, you must identify any associated autoimmune diseases, such as thyroiditis, rheumatoid arthritis, or systemic lupus erythematosus, as these can influence perioperative management and recovery.
Are there specific preoperative factors that predict the risk of postoperative crisis or prolonged ventilation, particularly for those undergoing thymectomy?
Yes, retrospective studies, particularly in patients undergoing transsternal or videoscopic thymectomy, have identified several factors associated with an increased need for postoperative ventilation. These include a history of prior myasthenic crisis, severe bulbar symptoms preoperatively, presence of significant respiratory muscle weakness, for example, vital capacity less than 2.9 liters, and a long duration of MG symptoms. While specific factors can vary across studies, a comprehensive assessment of bulbar and respiratory function is consistently identified as key for risk stratification.
And what's the indispensable role of preoperative consultation with the patient's neurologist?
Preoperative consultation with the patient's neurologist is absolutely essential and non-negotiable. This collaboration ensures a seamless continuum of care. This consultation should involve detailed planning for postoperative care, a clear understanding of the possibility and criteria for intensive care unit, ICU admission, and meticulous planning for the postoperative management of their anticholinesterase medication. Their chronic immunotherapies can generally be safely resumed once the patient is able to tolerate oral medications.
Moving to premedication, it sounds like a less is more approach is critically important for these patients.
That's precisely right. In many cases, premedication with sedatives can and should be avoided simply by providing reassurance and a thorough explanation of the expected procedures to the patient. This helps reduce anxiety without adding respiratory depressant effects. If premedication is deemed absolutely essential, administer the smallest effective dose incrementally, for example, midazolam, 0.5 milligram intravenously with continuous monitoring for any signs of bulbar weakness or respiratory compromise. The goal is always to minimize any respiratory depression.
When it comes to the choice of anesthetic technique, what methods minimize neuromuscular impact for these patients and why?
Whenever possible, local or regional anesthesia should be utilized. These techniques avoid systemic medications that can depress respiration or interfere with neuromuscular transmission. For peripheral procedures, consider relatively low-level neuraxial anesthesia, either epidural or spinal or peripheral nerve blocks. These approaches isolate the anesthetic effect to the surgical site, minimizing systemic impact on MG symptoms.
Are there specific local anesthetics to prefer or avoid? And what's the rationale behind that choice?
If local anesthetics are used, it's generally recommended to choose amide local anesthetics like ropivacaine, mepivacaine, bupivacaine, or lidocaine over esters such as chlorbracaine. The theoretical concern with esters is that anticholinesterases, which are commonly used for MG treatment to increase acetylcholine levels at the NMJ, may impair the hydrolysis of ester local anesthetics by competing for pseudocholinesterase, potentially leading to a prolonged block. However, it's worth noting there are no direct, robust studies providing definitive evidence of this effect in clinical practice, but it remains a theoretical concern.
And what about neuraxial anesthesia, particularly at higher levels? What are the limitations or dangers for an MG patient?
Mid-thoracic or higher levels of neuraxial anesthesia can result in paralysis or significant weakness of accessory muscles of breathing, such as the intercostals. Patients with any preoperative respiratory compromise or bulbar weakness may not tolerate such levels of motor block, as their already weakened diaphragm and accessory muscles may become insufficient for adequate ventilation. Therefore, careful consideration and meticulous monitoring of respiratory function are paramount if these techniques are used at higher levels.
Here's where it gets really interesting for the intensivist and arguably the most challenging aspect of perioperative care. Induction and maintenance of anesthesia, especially the neuromuscular blocking agents or NMBA dilemma. What are the overarching goals here to ensure patient safety?
The overarching goals during induction and maintenance of anesthesia are critical. We must meticulously prevent prolonged effects on respiratory and bulbar muscles, and we must ensure rapid and complete recovery of neuromuscular function at the end of surgery to facilitate safe extubation.
And regarding NMBAs, what's the absolute general rule of thumb for MG patients, and why such extreme caution?
As a general rule, we advocate for extreme caution in the use of NMBAs in patients with myasthenia. The ideal scenario, whenever surgically feasible, is to avoid NMBAs entirely. We recognize this isn't always possible, but it should be the default approach. The reason for such caution stems from their profoundly altered neuromuscular transmission.
Why is their response to NMBAs so variable and unpredictable compared to normal patients? This seems like a critical point for intensivists.
Their response is highly variable and unpredictable, even in patients with only ocular MG or those in clinical remission, making dosing extremely challenging. Myasthenic patients inherently have fewer functional acetylcholine receptors, so even a small dose of an NMBA can have an exaggerated effect. They also exhibit a variable response to NMBA reversal, which complicates achieving full recovery. Furthermore, there's always the possibility of inducing a cholinergic crisis if anticholinesterase medication is overdosed in an attempt to reverse paralysis.
So, are they more sensitive or resistant to specific types of NMBAs, and how does their anticholinesterase treatment factor in?
This is a crucial distinction. They tend to be resistant to depolarizing NMBAs, such as succinylcholine, because they have fewer functional AChRs for the succinylcholine to bind to and depolarize effectively. However, paradoxically and importantly, they are very sensitive to non-depolarizing NMBAs, like rocuronium or vecuronium, often requiring significantly lower doses than healthy individuals.
Wow, okay, resistant to depolarizing, sensitive to non-depolarizing. Got it.
Exactly. Furthermore, their ongoing treatment with anticholinesterase medication, which increases acetylcholine levels, directly affects the degree of muscle relaxation and the duration of action of any NMBAs you might administer, making their response even more unpredictable.
Given this unpredictable and altered response, what's the key to safe administration if NMBAs are absolutely unavoidable?
Monitoring is absolutely key. If NMBAs must be administered for surgical access or intubation, the degree of neuromuscular blockade should optimally be assessed with a quantitative train of 4 TOF nerve monitor. This precise objective monitoring allows us to guide dosing and, critically, to ensure that reversal to a train of 4 ratio, or TOFR, greater than 0.9 can be objectively verified before considering extubation. Clinical assessment alone is just unreliable.
And what's the preferred reversal strategy if non-depolarizing NMBAs are used, especially considering the challenges of reversal in MG?
If non-depolarizing NMBAs like rocuronium or vecuronium are necessary, we strongly suggest using them at the lowest doses required to achieve the desired level of paralysis and then reversing them with Sugammadex. Sugammadex is highly effective at encapsulating rocuronium and vecuronium, providing a rapid and complete reversal independent of the anticholinesterase system. If Sugammadex is unavailable, the use of non-depolarizing NMBAs should be avoided if at all possible due to the inherent challenges and risks of reversal with conventional anticholinesterases like neostigmine, which can precipitate a cholinergic crisis.
Now, a critical distinction that often appears on board exams. How do Lambert-Eaton myasthenic syndrome, or LEMS, patients respond to NMBAs compared to MG patients? This is a key diagnostic and management point.
This is a vital difference and a common board question. Unlike myasthenia gravis patients who are resistant to depolarizing NMBAs but very sensitive to non-depolarizing ones, LEMS patients are sensitive to both depolarizing and non-depolarizing NBAs. This means that in LEMS, you'd expect an exaggerated response to any NMBA, necessitating even lower doses and meticulous monitoring than in MG, and often resulting in prolonged paralysis. While anesthesia concerns for LEMS patients are otherwise broadly similar to those for MG, that specific NMBA sensitivity profile is unique to LEMS due to the underlying presynaptic defect in acetylcholine release.
Let's move to a crucial aspect for any intensivist. Medications to avoid or use with caution, the critical list. What's the general rule of thumb here, given the inherent fragility of MG patients?
The general rule is to maintain an extremely high index of suspicion. In generalized MG, you should assume that any medication may have the potential to exacerbate the condition. Therefore, you must carefully and vigilantly watch for worsening symptoms following the introduction of any new medication. Determining if the association with clinical worsening is coincidental or causal might even require a cautious withdrawal of the medication and then a re-challenge, though this should be done with extreme care in a monitored setting.
Are there specific classes of drugs or examples that are particularly notorious for exacerbating MG, and what's the mechanism of their detrimental effect?
Absolutely. Beyond the general rule, all respiratory depressants, such as benzodiazepines, opioids, and sedatives, should be used with extreme caution because they directly depress the central respiratory drive, compounding the inherent risk of respiratory compromise from muscle weakness in FMG patients. Specific drug classes and examples that are commonly associated with worsening NG symptoms due to various mechanisms, often interfering with neuromuscular transmission, include anesthetic agents. As discussed, neuromuscular blocking agents, rocuronium, vecuronium, succinylcholine are high risk. Antibiotics, aminoglycosides like gentamicin, tobramycin. These can impair neuromuscular transmission by reducing presynaptic acetylcholine release and having a Curare-like postsynaptic blocking effect. Fluoroquinolones like ciprofloxacin, levofloxacin. These can also exacerbate weakness, though the exact mechanism is less clear, possibly related to CNS effects or direct NMJ effects. Macrolides like azithromycin, erythromycin. Similar to fluoroquinolones, they can worsen MG, possibly via effects on calcium channels or the NMJ cardiovascular drugs. Beta blockers, like metopropranolol, these can exacerbate weakness by blocking beta-adrenergic receptors, affecting muscle function. Procainamide and quinidine. These antiarrhythmics have direct neuromuscular blocking effects. Others, botulinum and foxin, directly interferes with acetylcholine release. Chloroquine and hydroxychloroquine can directly impair neuromuscular transmission. Deferoxamine, mechanism unclear but reported to worsen MG glucocorticoids, especially high doses early on, causing that transient steroid dip. Statins, while mainly causing myopathy, can rarely exacerbate MG. Immune checkpoint inhibitors. These cancer drugs can induce severe, new-onset MG or exacerbate pre-existing MG, iodinated contrast, can transiently worsen MG symptoms in some. Magnesium. This is extremely important, especially for obstetric patients. Magnesium has a direct neuromuscular blocking effect and can severely worsen MG, even precipitating crisis. Penicillamine can induce MG quinine, has a direct neuromuscular blocking effect.
Moving on to postoperative care, vigilance for crisis is paramount. How do we individualize monitoring for these MG patients in the immediate postoperative period?
The need for postoperative monitoring and/or hospital admission for MG patients must be highly individualized. This decision should be based on a combination of their clinical features. For example, severity of preoperative bulbar and respiratory weakness, the specific surgical procedure performed, the type of anesthetic administered, UAG with or without NMBAs, and their intraoperative and immediate postoperative courses, e-SPAMD, prolonged paralysis, or difficult emergence. It also depends on their need for specific postoperative care, including pain relief, which itself can affect respiratory drive. Again, thorough preoperative consultation with the patient's neurologist is essential for this complex planning.
What are the specific, often subtle signs of respiratory compromise that we should be looking for in the postoperative period, especially during emergence and in the PACU?
Just as in the acute crisis, an increase in respiratory rate coupled with shallower tidal volume breaths is an early and crucial sign of impending respiratory fatigue. You might also observe the subtle use of accessory muscles of respiration or paradoxical movement of the abdomen, even in patients who are still intubated at the end of surgery, indicating diaphragmatic weakness or fatigue. While spontaneously breathing patients may initially show hypocapnia from hyperventilation, a rise in partial pressure of carbon dioxide, PCO2, is a definitive and alarming sign of impending respiratory failure and mandates immediate action. Other signs include difficulty clearing secretions, a weak cough, and poor vital capacity or negative inspiratory force measurements if the patient is cooperative enough for testing.
Are there specific contraindications for non-invasive ventilation or scenarios where it might fail or be dangerous that we should be particularly mindful of in MG patients post-op?
Yes, non-invasive ventilation, NIV, can be a bridge, but has critical limitations and contraindications in MG. Be acutely aware of scenarios where NIV might fail or be contraindicated, which are often present in these complex patients. These include facial or neurological surgery, trauma or deformity making mask fit impossible, significant airway obstruction like a tumor, inability to cooperate or protect the airway, think active vomiting, inability to clear secretions, severe swallowing disorder with high aspiration risk.
Right, airway protection is key.
Absolutely. Other contraindications include an anticipated prolonged duration of mechanical ventilation, maybe 4 to 7 days or longer, suggesting need for a more definitive airway, recent esophageal or gastric anastomosis where positive pressure could be harmful, multiple contraindications present, or insufficient staffing support to manage NIV safely and vigilantly, as these patients can decompensate rapidly.
And finally, if we suspect a cholinergic crisis in the postoperative period, perhaps due to overdosing of anticholinesterase medication, what's the immediate and definitive management strategy?
If a cholinergic crisis is suspected, which presents with symptoms of muscarinic excess like bradycardia, salivation, lacrimation, meiosis, bronchospasm, cramps, diarrhea, and profound weakness, you should immediately administer atropine, maybe zero point 0.4 to 2 milligram IV, or glycopyrrolate, 0.2 to 1 milligram IV, to counteract the muscarinic effects. Crucially, you must simultaneously withhold further anticholinesterase medication as the crisis is caused by an excess of these agents. Repeated dosing of the anticholinergic may be required to fully reverse the muscarinic effects and stabilize the patient.
Okay, let's just pause for a moment and bring together the critical takeaways from our discussion on acute crisis and perioperative management. For intensivists, our role in myasthenia gravis is profound, especially in anticipating and managing myasthenic crisis, which is a life-threatening neuromuscular respiratory failure, most commonly triggered by infection. We've highlighted the extreme nuances of anesthetic choice, with paramount caution around neuromuscular blocking agents due to their unpredictable resistance to depolarizing NMDAs, but very sensitive to non-depolarizing ones and the critical role of quantitative train-of-4 monitoring. We also covered that extensive, critical drug list to avoid or use with caution, including aminoglycosides, fluoroquinolones, macrolides, beta blockers, and especially magnesium. Remember that LEMS patients are sensitive to both depolarizing and non-depolarizing NMDAs, a key differentiator. So for a board-style scenario, you're managing a patient with acute neuromuscular weakness requiring intubation. Initial assessment suggests myasthenia gravis, but you're also strongly considering Lambert-Eaton myasthenic syndrome.
You need to use a neuromuscular blocking agent to facilitate intubation. What's the key difference in NMDA response between MG and 11S patients that would guide your choice in dosing, and what specific monitoring would be essential?
The key difference lies in their sensitivity to NMDAs. While MG patients are resistant to depolarizing NMDAs like 6-phenylcholine and very sensitive to non-depolarizing NMDAs like rocuronium, LEMS patients are sensitive to both depolarizing and non-depolarizing NMDAs. This means that in LEMS, you'd expect an exaggerated and prolonged response to any NMDA, necessitating even lower doses and meticulously cautious titration than in MG. In either case, quantitative train-of-4 monitoring is absolutely essential to precisely guide dosing and ensure adequate but not excessive paralysis and safe reversal.
That's a vital distinction for patient safety. Now we move to Chapter 3, Chronic Immunotherapy for MGG, a deep dive into pharmacological strategies. This is about managing the disease long-term, and while it might not always be our direct purview in the ICU, understanding these strategies helps us contextualize chronic medication lists and anticipate how certain therapies might impact acute presentations. What are the general treatment principles and goals for the long-term management of myasthenia gravis?
The core objective of therapy in MG is twofold and equally important: to minimize both the clinical manifestations of the disease, meaning the weakness and functional limitations, and crucially, to minimize the burden of adverse effects from the medications themselves, as these therapies are often lifelong.
Is achieving remission a realistic or even common goal for these patients with chronic treatment?
Yes, absolutely. MG is a chronic but fundamentally treatable disease, and a significant number of patients can achieve full and sustained remission of symptoms, often accompanied by full functional capacity with appropriate and timely treatment. The most common and often achievable goal is minimal manifestations, meaning either no symptoms at all or mild and stable residual weakness that, crucially, causes no functional limitation in their daily lives. For those patients who achieve full remission or minimal manifestations, pharmacotherapy may be gradually weaned slowly, but treatment should always be promptly resumed if symptoms relapse to prevent further worsening.
So it's not typically a single drug solution, but often a combination approach.
Precisely. Successful treatment of MG nearly always rests on a timely combination of different interventions, often involving symptomatic treatments, corticosteroids, and steroid-sparing immunosuppressants. This isn't usually a monotherapy disease, and personalized medicine is key. It implies individual assessments of the benefit-risk balance for each patient, considering their comorbidities and lifestyle, and equally important, actively engaging the patient in their treatment decisions. It's a shared journey.
Let's quickly touch on routine vaccinations, which are critical for preventing infections that can trigger MD exacerbations. What's the general guidance for MG patients, especially those on immunosuppressive therapy?
Routine vaccination is highly recommended for MG patients, particularly those on immunosuppressive therapy, as they are at increased risk of infection. Annual seasonal influenza vaccination is crucial for all individuals receiving immunosuppressive therapy and for those with neurological conditions, including neuromuscular disorders like generalized MG or even ocular MG within 3 years of onset, as these conditions can compromise the handling of respiratory secretions and increase pneumonia risk. The inactivated intramuscular influenza vaccine is considered safe and is preferred.
What about pneumococcal and live vaccines? Are there specific considerations there?
The pneumococcal vaccine is also strongly recommended for all individuals with chronic pulmonary conditions and for those on immunosuppressive therapy. For all generalized MG patients and those with ocular MG within 3 years of onset, it's advised due to the significant risk that a respiratory infection, like pneumococcal pneumonia, may trigger an MG exacerbation or crisis. Crucially, patients being treated with immunosuppressive therapy for MG should not receive live attenuated vaccines, such as the intranasal influenza vaccine or the live attenuated varicella or zoster shingle vaccine, due to the risk of opportunistic infection from the attenuated virus.
And what about COVID-19 vaccination, given the ongoing discussions around it?
COVID-19 vaccination has generally not been associated with worsening of MG symptoms in retrospective studies and has, in fact, been linked to a reduced risk of hospitalization and mortality in MG patients who developed COVID-19 infection. So it's generally safe and beneficial for MG patients, and they should be encouraged to receive it according to public health guidelines.
Now, let's talk about glucocorticoids, often the cornerstone of immunosuppression in MG. What's the initial therapy recommendation, and how do we typically approach dosing?
For most patients with MG who remain significantly symptomatic despite symptomatic treatment with pyridostigmine, or who become symptomatic again after initial temporary response to it, glucocorticoids are recommended as initial immunotherapy. This is supported by grade 1B evidence indicating a strong recommendation. A typical regimen starts with oral prednisone at 20 milligrams daily.
And why the emphasis on gradual dose escalation with prednisone? What's the specific phenomenon we're trying to avoid, and how common and severe can it be?
The reason for this gradual escalation is critical. It's advised to avoid the early transient worsening of weakness, often referred to as the steroid dip, that can occur with the initiation of high-dose glucocorticoids. This transient worsening typically occurs within 5 to 10 days after initiating glucocorticoids and usually lasts for approximately 5 or 6 days. It can affect a significant proportion of patients, up to 50%, and alarmingly can lead to severe respiratory failure requiring mechanical ventilation in up to 10% of patients.
Wow, 10% requiring ventilation is significant.
It really is. This concern is significantly ameliorated when the patient receives concurrent rapid-acting treatment with plasma exchange, or IVG, which can provide a bridge of immune modulation until the steroids take full effect.
So if a rapid response is needed in an acute setting, how might this strategy be adapted to minimize the steroid dip risk?
If a rapid response is urgently needed, for instance in a severe exacerbation, a higher dose of prednisone, typically 30 to 50 milligrams daily, can be initiated from the beginning. However, it must be combined with intravenous immunoglobulin or plasma exchange. This combination strategy provides rapid immunomodulation, thereby proactively avoiding that potentially life-threatening steroid dip and stabilizing the patient more quickly.
Once patients achieve an acceptable MG status, how are steroids typically tapered? And how quickly do they generally show an effect?
Steroids typically show a clinical effect within 2 to 4 weeks in about 75% of patients, with the maximal effect often peaking after a mean of 5.5 months. This highlights their relatively rapid onset compared to other immunosuppressants. Once an acceptable MG status is obtained, the steroid dose should be gradually tapered over months to the lowest effective dose to maintain that status and minimize long-term side effects. Alternate day dosing is often preferred once stable, as it can further minimize chronic side effects.
Given the chronic nature of steroid use, what are the key adverse effects we must monitor for, and what preventative measures should be in place?
Regular and vigilant monitoring for adverse effects is absolutely crucial due to the systemic impact of corticosteroids. All patients on steroids should be routinely monitored for blood pressure, body weight, bone mineral density, like with regular DEX-face scans for osteoporosis, risk blood glucose levels for steroid-induced diabetes, and also for sleep and mood problems. Yearly checks for cataracts and glaucoma are also recommended due to the ocular side effects of long-term steroid use. While a histamine 2 blocker doesn't need to be used routinely, it should definitely be given to patients with a history of peptic ulcer disease or those who develop symptoms of gastritis while on steroids to prevent GI complications.
Are there any special considerations for specific patient populations, like those with pre-existing comorbidities or children, when considering steroid therapy?
Yes, certainly. Patients with pre-existing conditions like osteoporosis, obesity, diabetes mellitus, and mental disorders have a particularly high risk of experiencing significant corticosteroid side effects. For such patients, steroids should ideally be given only short-term at a lowest possible dose and only until another immunosuppressant, which might have a better long-term side effect profile, has had time to provide a good therapeutic response. In children, where growth and development are concerns, short-term treatment and low doses are particularly important to minimize adverse impacts. We also routinely consider pneumocystis jirovecii pneumonia, PJP, prophylaxis for patients on significant doses of glucocorticoids, specifically 20 milligrams of prednisone daily or more for a month or longer, especially when this is combined with a second immunosuppressive drug due to the increased risk of opportunistic infection.
Now let's explore conventional immunosuppressants, which play a significant role as steroid-sparing strategies and are often used long-term. What's their overall role in MG management, and why are they so important?
Non-steroidal immunotherapy plays an extremely important and often indispensable role in MG management. These agents are used for patients who have an insufficient response to glucocorticoids, for those who cannot taper glucocorticoids below an acceptable level without their symptoms returning, and critically, as a steroid-sparing therapy for patients who are experiencing toxicities or unacceptable side effects from chronic glucocorticoid use. Immunotherapy should be offered to over 80% of patients who are not meeting treatment goals despite optimal symptomatic treatment.
What's the typical onset of action for these conventional immunosuppressants, and what are their main long-term benefits?
These drugs generally have a delayed response, typically taking 1 to 6 months to show an initial clinical effect, with the full maximal effect sometimes taking more than 1 year to manifest. However, their long-term benefits are substantial and foundational to chronic MG management. They enable the gradual and often complete tapering of steroids, significantly improve the overall clinical response, and crucially reduce the risk of debilitating long-term steroid side effects. They can even be used alone as primary therapy if steroids are contraindicated or simply refused by the patient due to concerns about side effects.
Let's break down some of the most common conventional immunosuppressants used for MG, starting with azathioprine. What's its mechanism of action, and what's the absolutely crucial pre-treatment screening required before initiating it?
Azathioprine functions as a purine analog that reduces both T and B cell proliferation, thereby dampening the autoimmune response. The crucial pretreatment screening, which cannot be overstated, is for variants in the thiopurine methyltransferase, or TPMT, gene. This enzyme, TPMT, is responsible for metabolizing azathioprine. Approximately 1 in 300 individuals is homozygous for a genetic variant that leads to very low or absent TPMT enzyme levels. Such patients must not receive azathioprine because they cannot metabolize the drug effectively, which puts them at a life-threatening risk of severe bone marrow suppression, leading to profound myelosuppression.
Okay, so TPMT testing is non-negotiable before starting azathioprine.
Absolutely non-negotiable. Patients who are heterozygous for a genetic variant generally have low enzyme activity but can often tolerate azathioprine at lower than usual doses, albeit with closer monitoring.
How is this TPMT testing typically performed? What are the dosing guidelines? And what specific monitoring is required once therapy is initiated?
Testing for TPMT deficiency can be done either by genotype, detecting the specific genetic variants, or by phenotype, measuring the enzyme levels. The erythrocyte enzyme level assay in serum is often preferred due to its lower cost and ready availability in many labs. You should absolutely avoid azathioprine if the TPMT activity is absent or very low, typically below 20 mUl. In Nordic countries, where extensive clinical experience with azathioprine for MG exists, a starting dose of 2 to 3 mg/kg per day is usually considered first line for both adults and children. Regarding monitoring, the most common side effect is a flu-like illness presenting with fever, nausea, vomiting, and general malaise, which occurs in about 10% of patients within the first few weeks of initiation. This is often an idiosyncratic reaction, and the drug should be immediately discontinued. Symptoms will quickly abate.
Right.
Less common but far more serious potential adverse effects include hepatotoxicity, significant suppression of the white blood cell count, leukopenia, and pancreatitis. For these reasons, it is absolutely essential to monitor with a complete blood count, CBC, and liver function tests, LFTs, monthly for at least 6 months after initiation and then periodically thereafter. The dose should be decreased if the white blood cell count falls below 4,000 cells and completely discontinued if it drops below 3,000 cellometer. Similarly, it should be discontinued if liver function tests are more than mildly abnormal or continue to rise. If symptoms suggestive of pancreatitis develop, such as severe abdominal pain, serum amylase and lipase should be checked, and azathioprine discontinued if elevated.
Next, mycophenolate mofetil. What's its mechanism, typical onset, and critically its specific pregnancy risk implications for women of childbearing age?
Mycophenolate mofetil also functions to reduce both T and B cell proliferation by inhibiting inosine monophosphate dehydrogenase, an enzyme crucial for purine acid synthesis. Its onset of action is typically delayed, taking 6 to 12 months, with a maximal therapeutic effect sometimes taking 1 to 2 years. Its critical consideration, paramount for women of childbearing age, is its pregnancy risk. It carries a moderate to high risk of fetal harm, including significant birth defects. Therefore, its use for patients who may become pregnant should be reserved for those with severe disease who are using reliable and highly effective means of contraception. It's also generally not recommended for breastfeeding mothers due to potential transfer into breast milk. Dosing is typically 1 to 2 grams daily, often considered as a secondary alternative in clinical practice.
What about methotrexate? Is it commonly used, and what are its particular considerations?
Methotrexate also works to reduce T and B cell proliferation, with an onset of action similar to mycophenolate, generally 6 to 12 months. However, it is infrequently used in MG compared to azathioprine or mycophenolate. Like mycophenolate, it is not recommended for women of childbearing age or during breastfeeding due to potential fetal harm and passage into breast milk. A typical dose might be 20 milligrams per week as a secondary alternative. Cyclophosphamide is another older, more potent agent in this class that is used even less frequently in MG due to its significant toxicity, and similarly, it's strictly not recommended for women of childbearing age or breastfeeding.
Let's discuss cyclosporine, another conventional immunosuppressant. How does it work? What's its onset? And what are its major limitations that influence its use?
Cyclosporine is a calcineurin inhibitor. It selectively inhibits calcineurin, a phosphatase crucial for T cell activation. By doing so, it impairs interleukin-2 production, inhibits T helper cells, and generally dampens T lymphocyte-dependent immune responses, thereby reducing the autoimmune attack. Its onset of action is relatively quicker than azathioprine or mycophenolate, typically around 6 months, with maximal effect seen around 7 months. However, its use as a first-line steroid-sparing agent is significantly limited by concerns about kidney toxicity, nephrotoxicity, hypertension, and numerous drug interactions, particularly with CYP3A4 inhibitors and inducers, which necessitate therapeutic drug monitoring. Selective use during pregnancy is warranted only when the benefits clearly outweigh the potential risks and under very close medical supervision.
And how does tacrolimus compare to cyclosporine, especially regarding its side effect profile and use in MG?
Tacrolimus is another calcineurin inhibitor that primarily blocks T cell activation, similar to cyclosporine, but its onset of action is generally quicker than azathioprine or mycophenolate. A key advantage for MG patients is that it is often considered less nephrotoxic than cyclosporine, especially at the lower doses used for MG, and nephrotoxicity has generally not been a limiting factor in MG treatment experience. However, it does have its own spectrum of side effects, which include hyperglycemia, potentially leading to new-onset diabetes, hypomagnesemia, tremor, and paresthesias. These generally resolve with dose adjustment or magnesium replacement. While rare, more serious adverse events, including malignancies like lung and kidney cancer, have been reported in transplant populations, though investigators felt they were unlikely related to tacrolimus in the context of MG studies. Despite its advantages, the potential for severe side effects still exists. Regarding pregnancy, tacrolimus is regarded as having very low or no increased risk compared to other immunosuppressants, but it should still be used at the lowest effective dose. Typical Nordic dosing is 3 milligrams daily as a secondary alternative.
Finally, let's discuss immunoglobulins, both IVIG, or intravenous immunoglobulin, and plasma exchange, or PLEX. What's their primary role in MG management, and what's their mechanism of action?
These therapies provide rapid, albeit transient, immunomodulation. Their mechanisms are complex and involve multiple effects. IVIG contains a broad spectrum of antibodies that can neutralize pathogenic autoantibodies, block Fc receptors, and modulate cytokine production. PLEX physically removes pathogenic antibodies and other immune mediators from the patient's plasma. Their primary role is as the first-line treatments for myasthenic crises and acute exacerbations. They are almost always initiated together with careful observation, often in an intensive care setting, due to their rapid onset of action.
And how do they tie into that critical steroid dip phenomena we discussed with glucocorticoids?
Their quick onset of action is invaluable because it helps to proactively prevent that transient worsening, or steroid dip, that would otherwise occur due to the initiation of high-dose glucocorticoids. By providing immediate immunomodulation, IVG or PLX can bridge the gap until the slower-acting corticosteroids take full therapeutic effect, thereby stabilizing the patient and reducing the risk of a severe transient exacerbation.
Are IVG and PLX commonly used as maintenance therapy for chronic MG, or are they reserved for acute situations?
Generally, immunoglobulins, whether given intravenously or subcutaneously, are rarely used as long-term maintenance therapy due to their high cost, logistical burden, and transient effect. A recent study, for instance, found no steroid-sparing effect of IV-IG when used long-term, suggesting it doesn't effectively replace other maintenance immunosuppressants. While they are safe and fast-acting for acute situations, the data on their long-term effectiveness as maintenance therapy are generally insufficient to justify widespread chronic use. The number of immunoglobulin doses and dosing intervals, when used, should always be individualized based on acute needs or specific clinical scenarios. It's also important to note that IVIG and plasma exchange are considered safe rescue therapies during pregnancy and in the postpartum period, making them crucial options in those contexts.
Okay, let's bring it all together for this chapter on chronic immunotherapy. We've covered a rationale for chronic immunotherapy, emphasizing the goals of achieving minimal manifestations while reducing side effect burden. We walked through glucocorticoids as the cornerstone, stressing gradual escalation to avoid the steroid dip, and the acute role of IVIG-PLX to prevent it. We then delved into conventional immunosuppressants like azathioprine, with that critical TPMT screening mycophenolate, highlighting its teratogenicity, methotrexate, cyclosporine, and tacrolimus, emphasizing their delayed onset and steroid-sparing role, along with their key side effects and monitoring requirements. And we established that while IVG bring and PLX are vital for acute crises, they're not typically used for long-term maintenance. So for a quick board-style question, a 35-year-old woman with newly diagnosed generalized myasthenia gravis is being considered for azathioprine as a steroid-sparing agent. Prior genetic testing reveals she is homozygous for a specific genetic variant leading to absent thiopurine methyltransferase (TPMT) enzyme levels. Should azathioprine be prescribed for this patient? And what is the absolute rationale for your decision?
No, azathioprine should absolutely not be prescribed for this patient. The rationale is critical. Individuals who are homozygous for a genetic variant causing absent TPMT enzyme levels cannot metabolize azathioprine effectively. This results in toxic accumulation of the drug's active metabolites, which puts them at an extremely high life-threatening risk for severe and potentially fatal bone marrow suppression. This is precisely why TPMT screening is a mandatory pre-treatment step, especially before initiating azathioprine, to identify and protect these vulnerable patients.
That's a perfect encapsulation of a critical safety point.
Uh.
Now we move to Chapter 4, Advanced Therapies and Holistic Care, the evolving frontiers in MG management. This is where we see cutting-edge treatments emerging, often with novel mechanisms. What's the general context for these newer biologic therapies, and how do they fit into the evolving treatment paradigm for MG?
The landscape of MG therapy is rapidly expanding, offering new hope, especially for patients who haven't responded adequately to conventional treatments. Several new agents, often quite expensive, have recently been approved or are in advanced clinical development. These represent a significant expansion of our therapeutic options beyond steroids and conventional immunosuppressants. Their actual use, however, often depends on local availability, specific refunding policies, and detailed cost-benefit analyses within different healthcare systems.
And what's their general time to onset, and how does that make them particularly valuable in certain clinical scenarios, perhaps even for intensivists?
The time to onset of effect for some of these newer agents can be remarkably quick, often as early as 2 weeks. This rapid action makes them particularly valuable as bridge therapy to slower-acting conventional immunotherapies like azathioprine or mycophenolate. They are especially useful for patients in whom glucocorticoid use is undesirable or needs to be minimized, for example, in patients with poorly controlled diabetes, severe osteoporosis, or active infections where steroids pose unacceptable risks or could worsen comorbidities. They offer a way to get rapid immune control without the initial steroid dip.
Let's dive into some specifics, starting with efgartigimod alpha. What's its unique mechanism and its evolving role in MG management?
Efgartigimod alpha is a fascinating new agent. It's an IgG antibody Fc fragment molecule, a humanized FcRn antagonist, specifically designed to promote the accelerated degradation of pathogenic IgG autoantibodies by binding to the neonatal Fc receptor, FcRn, which normally recycles IgG. By blocking FcRn, efgartigimod causes these antibodies to be broken down more quickly. Its evolving role is quite broad. It can be considered early in the course of the disease, sometimes even instead of high-dose glucocorticoids, particularly in patients like those with diabetes where GCs pose unacceptable risks or side effects. It can also be used as that crucial bridge therapy to slower-acting conventional agents, or as chronic periodic maintenance therapy for sustained symptom control. However, it's important to note that long-term data on its absolute optimal role and duration are still being gathered.
What are the common and post-marketing adverse effects for efgartigimod alpha that we should be aware of?
Common reported effects in phase 3 trials included headache, nasopharyngitis, and upper respiratory infection, indicating its impact on immune function. Other adverse effects have included transient leukopenia and the rare development of pathogenic serum antibodies. Post-marketing surveillance reports have also indicated infusion-related reactions, such as transient hypertension, chills, and abdominal pain, as well as hypersensitivity reactions, including hypotension and even anaphylaxis, which require careful monitoring during and after infusion.
Well, next, rozanolixizumab. How does it work? What's its dosing, and what's its role in MG?
Rozanolixizumab is another Fc receptor monoclonal antibody, similar in class to efgartigimod, that also accelerates the degradation of pathogenic IgG autoantibodies. It's administered as a subcutaneous infusion weekly for 6 weeks. The dosing is weight-based, specifically 420 milligrams for patients weighing less than 50 kilograms, 560 milligrams for those between 50 and 100 kilograms, and 840 milligrams for those over 100 kilograms. Subsequent cycles are determined based on the initial response observed and the patient's individual needs. It's notable that it can be used in both AChR-positive and MuSK-positive MG, offering a broader therapeutic option for different antibody subtypes.
And its adverse effects profile?
Common adverse effects with rozanolixizumab include headache, infections, often respiratory, and diarrhea. In a particular trial, significant improvement in MG-ADL scores was observed by day 43, and importantly, most adverse events were reported as mild to moderate and generally manageable.
Now let's turn to ravulizumab. How does it work? What's its distinct advantage in terms of dosing? And are there any critical safety notes that an intensivist absolutely must know?
Ravulizumab is a humanized monoclonal antibody that operates by specifically binding with the terminal complement protein C5. By doing so, it prevents the cleavage of C5 into C5a and C5b, thereby inhibiting the formation of the membrane attack complex, or MAC. This MAC is a key component of the complement system responsible for directly destroying the postsynaptic membrane at the neuromuscular junction in MG. Structurally, it's very similar to eculizumab, but it has been engineered to allow for less frequent dosing, specifically a maintenance dose every 8 weeks, which is a significant convenience and adherence advantage for patients compared to weekly or biweekly infusions.
So there's 8 weeks. That's a big difference.
Huge difference. Like efgartigimod and other newer biologics, ravulizumab can be considered early in the disease course instead of glucocorticoids for rapid control, as bridge therapy to slower-acting conventional agents, or as chronic periodic maintenance therapy. Long-term data are still warranted to define its full impact across the disease spectrum. Dosing is variable and weight-based, typically starting with a loading dose, then a maintenance dose 2 weeks later, and then continued every 8 weeks. The critical safety note here, which is paramount for us as intensivists, is that ravulizumab significantly increases the risk of serious infections, particularly those caused by encapsulated bacteria, most notably Neisseria meningitidis. Therefore, patients must be immunized with meningococcal vaccines at least 2 weeks prior to receiving their first dose, and prophylactic antibiotics may even be considered as an additional precautionary measure in high-risk settings. In phase 3 trials, no treatment-limiting side effects were reported, and headache was the most frequent adverse effect, highlighting the importance of managing the specific infection risk.
What about zilucoplan? How does it compare? And what's particularly unique about its properties and potential for future therapies?
Zilucoplan is a macrocyclic peptide that, like ravulizumab and eculizumab, inhibits the cleavage of complement C5 and effectively prevents MSC formation. It also blocks the interaction of preformed C5b with C6 complement, further disrupting the complement cascade. Its key advantages include its self-administration via subcutaneous injection, rapid action, and convenient dosing, which greatly enhance patient autonomy and adherence. The most unique property of zilucoplan, because it's a peptide and not an IgG antibody, is that it is unaffected by the IgG recycling pathway mediated by FcRn. This means it's not influenced by FcRn inhibitors, opening up the exciting potential for combination with therapies that specifically target FcRn for synergistic approaches, offering a multi-pronged attack on the autoimmune process. It's FDA approved for AChR-positive generalized MG, though its exact long-term role in chronic treatment, early bridge maintenance, is still being fully elucidated.
And the critical safety note for zilucoplan, still meningococcal vaccine.
Yes, exactly. Similar to other complement inhibitors, all patients undergoing treatment with zilucoplan should receive vaccination against N meningitis due to the increased infection risk from terminal complement pathway inhibition. This prophylactic measure is non-negotiable.
Let's discuss eculizumab, which really paved the way for some of these newer complement inhibitors. What's its historical context, trial outcomes, and key adverse effects?
Eculizumab is also a complement inhibitor that binds to C5. It was the first complement inhibitor to show significant benefit in refractory AChR-positive MG, marking a major breakthrough. The larger REGAIN trial, while it did not meet its primary statistical endpoint for the MG-ADL, Activities of Daily Living Scale, at 26 weeks using a specific ranking methodology, did show significant benefit on most other pre-specified endpoints. These included significant improvement in the quantitative MG scale, QMG score, a reduced rate of MG exacerbations, and importantly, it also significantly improved perceived fatigue, a debilitating symptom for many patients. Based on these data, eculizumab was approved by the FDA and EMA for refractory AChR antibody-positive patients. Its open-label extension study further demonstrated maintained functional gains and significantly lower exacerbation rates over long-term follow-up, solidifying its role. Eculizumab infusions are generally well tolerated. Common reported adverse events in clinical trials include headache, nasopharyngitis, diarrhea, upper respiratory infection, arthralgias, and nausea. However, it's crucial to remember that there is an increased risk of infection, especially with encapsulated bacteria, due to the blockade of terminal complement activation. Thus, meningococcal vaccination is mandatory for patients on eculizumab, just as with ravulizumab and zilucoplan.
We also have nipocalimab, batoclimab, and cetralizumab in the pipeline. Can you briefly describe their mechanisms and what we know from their trial results?
Sure. Nipocalimab is an Fc receptor monoclonal antibody that also targets IgG autoantibodies, working through a similar mechanism to efgartigimod and rozanoliximab, administered as consistent, recurring intravenous infusions. Trial results showed greater improvement in MG-ADL scores compared to placebo, and common adverse events like infections and headaches occurred at similar rates in treatment and control groups. Batoclimab is another Fc receptor monoclonal antibody administered by 6 weekly subcutaneous infusions followed by 4 weeks of observation. Trial results demonstrated a greater proportion of patients with significant MG-ADL improvement compared to placebo, with most common treatment-related adverse events being peripheral edema, infection, and diarrhea. Satralizumab is an interleukin-6 IL-6 monoclonal antibody, potentially acting by targeting B-cell activation to reduce autoantibody production, as IL-6 is a key cytokine in B-cell differentiation. Trial results showed a modestly greater improvement in MG-ADL scores compared to placebo, and while serious adverse events were rare, common adverse events in the treatment group included infections, injection site reactions, and headache. These agents represent continued expansion of targeted therapies.
That's a lot of exciting new options. Let's shift to experimental and emerging therapies, truly the horizon of MG treatment. What's on the more distant horizon for future treatments, perhaps still in earlier trial phases?
These represent highly promising but currently unproven frontiers that are moving beyond broad immunosuppression to highly targeted cellular or molecular mechanisms. Inebilizumab, an anti-CD19 monoclonal antibody, is currently in phase 3 clinical testing for both generalized MuSK-MG and AChR-MG. The rationale here is that CD19 expression remains longer in plasma cell differentiation than CD20, which rituximab targets, potentially leading to a greater and more sustained effect on antibody-producing plasma cells. TK079, an anti-CD38 monoclonal antibody, also targets plasma cells for depletion. A phase 2 trial indicated no significant clinical effect up to week 32, though autoantibody levels did show a tendency to drop, suggesting a potential biologic effect. There's also a single case report of daratumumab, another anti-CD38 monoclonal antibody, showing substantial clinical improvement in a severe refractory MG case, highlighting the potential for plasma cell targeting therapies.
And what about cladribine?
Cladribine is an oral purine analog that selectively depletes lymphocytes, particularly B and T cells, by interfering with DNA synthesis. A case series of 13 patients with treatment-refractory MG showed clinical improvement in 11 of them, which is quite promising given their refractory status, but it's still preliminary evidence requiring larger trials.
Now let's talk about something truly revolutionary in other fields, like oncology, CAR-EC and CRAT cell therapies, or adoptive cellular therapy. What's the fundamental mechanism here, and why is it holding such immense promise for severe MG?
Adoptive cellular therapy is a groundbreaking approach. It involves harvesting a patient's own T cells from their blood, genetically modifying them in a laboratory to express a chimeric antigen receptor, or COR. This CAR is engineered to specifically target and recognize certain markers on disease-causing cells, like autoreactive B lymphocytes or plasma cells. These modified T cells are then expanded in vitro and reinfused back into the patient. Chimeric antigen receptor T, or CAR-RT, cell therapy is already transforming the treatment of certain hematological neoplasms, and it holds immense promise in revolutionizing how we manage severe refractory autoimmune diseases like MG by precisely targeting the cells responsible for autoantibody production.
And there's a specific investigational RNA-based CAR-T therapy called Descartes-08 that has shown intriguing early results. What were the trial outcomes, and importantly, what was particularly noteworthy about its safety profile, especially compared to DNA-based CAR-T therapies used in oncology?
Descartes-08, an investigational RNA-based rCRT therapy, has indeed shown promising outcomes in a Phase B clinical trial involving 14 adults with generalized MG. This therapy specifically targets the B-cell maturation antigen, or BCMA, which is highly expressed on mature B lymphocytes and plasma cells, the very cells producing the pathogenic autoantibodies in MG. The infusions led to significant reductions in MG severity scores, as measured by various clinical scales, over a follow-up period of up to 9 months.
Significant reductions, okay. And the safety.
Exactly. What's particularly noteworthy about its safety profile is a major breakthrough. The trial demonstrated effective disease alleviation with a remarkably favorable safety profile for up to 9 months. Crucially, the autologous RTARC-T preparation was successful even in individuals already on immunosuppressive therapy, which is important for MG patients. And perhaps most significantly, Descartes-08 was used without the need for lymphodepletion chemotherapy. Lymphodepletion chemotherapy is typically a prerequisite for conventional DNA-based CAR therapies to create space for the infused T cells, and is associated with significant adverse effects like neurotoxicity, severe cytokine release syndrome, CRS, and various blood abnormalities. The ability to achieve therapeutic effects without this preconditioning regimen is a huge advantage, potentially reducing the overall toxicity and making this therapy more accessible for patients with MG. This remarkable safety profile observed in this trial has laid the foundation for an ongoing Phase I placebo-controlled study.
So even with those advantages, CAR-T therapies aren't without their general side effects in other contexts, right? What are the main concerns, and how might CRT cells improve safety?
That's correct. Even with these advancements, the primary side effect generally associated with CAR-T cell therapy is cytokine release syndrome, or CRS, which is an inflammatory response that can range from mild constitutional symptoms like fever and fatigue to severe multi-organ dysfunction, including neurotoxicity. However, the hope is that well-designed and highly specific chimeric autoantibody receptor T, or CART cells, which are engineered to target cells producing specific autoantibodies, might significantly lower the risk of both CRS and off-target toxicity by being more precise in their targeting, leading to fewer systemic inflammatory effects.
Given all these emerging and experimental therapies, what's the general recommendation for their use at this stage? Are they widely available or for specific cases?
It's vital to stress that none of these listed experimental therapies currently have robust, large-scale evidence showing definitive clinical benefit and established safety profiles for widespread use in myasthenia gravis. Therefore, they should be considered only in highly selected, truly refractory, and very severe cases where standard therapies have shown an unsatisfactory effect or have been intolerable for the patient, and ideally within the context of clinical trials. They are not yet for routine use in the general MG population.
Let's discuss thymectomy, a surgical intervention that has a well-established role in MG. What's its purpose as an adjunct to pharmacotherapy?
Thymectomy, the surgical removal of the thymus gland, is indicated as an adjunct to pharmacotherapy for selected MG patients. Its primary purpose is to reduce symptoms, minimize long-term exposure to medications, particularly corticosteroids, and ultimately improve overall long-term outcomes, often by leading to remission or significant clinical improvement.
What are the precise indications for thymectomy? This is crucial for guiding patient selection.
There are a few key indications. First and foremost, Thymectomy should be undertaken early if a thymoma is suspected or confirmed via imaging, regardless of the severity of MG symptoms, as thymomas are associated with MG in about 20% of ACR-positive patients and have malignant potential. If the anterior mediastinal lesion isn't well circumscribed, or if the patient has systemic symptoms suggesting another diagnosis, a preoperative biopsy is necessary to confirm the diagnosis and rule out other mediastinal masses. Second, for non-thymomatous myasthenia gravis, meaning MG, without an associated thymoma, specifically an ACR antibody-positive generalized MG, thymectomy is generally recommended for patients up to the age of 50-65 years if they are not obtaining adequate remission or symptom control on symptomatic treatment alone.
How does it apply to ocular MG? Is thymectomy recommended for patients with purely ocular symptoms?
For non-thymomatous ocular MG, practice varies, and it's a more nuanced discussion. While prospective studies are limited for OMG, several case series have demonstrated a similar response to thymectomy in ocular MG as with generalized MG. Remission rates of 57 to 71% over more than 5 years have been reported after thymectomy in OMG patients. Furthermore, studies suggest a low rate of generalization to generalized MG after surgery, contrasting with an expected 50% generalization rate over that time frame in untreated ocular MG. This suggests a role in preventing progression, though definitive guidelines are still debated. A systematic review and meta-analysis found a 51% complete stable remission rate with thymectomy in OMG, though with some heterogeneity in the studies.
Are there age considerations that would typically limit thymectomy, or for whom is generally not recommended?
While no specific age limit is definitively established, it's generally advised against thymectomy for most patients aged 60 years and older who do not have a thymoma. This is based on the concern that surgical risks might outweigh potential benefits in this older age range, and older adults are also more likely to have atrophic changes in the thymus, which may indicate a lesser pathogenic role for the thymus in their disease. However, an individualized approach is always encouraged, balancing the patient's specific symptoms, comorbidities, and surgical risks versus potential long-term benefits.
Is thymectomy ever recommended for MuSK or LRP4 positive MG?
No, this is a crucial point for differentiation. Patients with MuSK antibody-positive MG do not typically require mediastinal imaging because thymic abnormalities and thymomas are generally not associated with MuSK antibodies. Crucially, thymectomy is not recommended for MuSK-positive patients, including MuSK-positive children, as they have consistently not been shown to benefit from the procedure. The role in LRP4-positive MG is also not established, and it is generally not recommended.
What preoperative preparation is necessary for thymectomy patients, especially those with significant symptoms?
All patients undergoing thymectomy should have a thorough preoperative anesthesia consultation to assess their surgical risk. For patients with significant preoperative respiratory or bulbar symptoms, it is absolutely warranted to optimize their condition prior to surgery. This typically involves treatment with plasmapheresis or intravenous immune globulin (IVIG) to reduce antibody levels and improve strength, thereby reducing perioperative risk and potential for postoperative crisis.
In the surgical approach itself, what's generally recommended?
Minimally invasive surgeries, such as video-assisted thoracoscopic thymectomy, VATS, is generally recommended for thymectomy over traditional open approaches, as it offers benefits like less pain, shorter hospital stays, and faster recovery, while still allowing for complete removal of thymic tissue. Special attention must be taken to ensure that all thymic tissue, including ectopic or cervical extensions, is completely removed to maximize potential long-term benefit.
Let's move to special considerations. Tailoring care for unique patient needs. First, pregnancy and breastfeeding, a delicate balance indeed for MG patients. What's the general risk for MG during pregnancy, and what planning should occur pre-pregnancy?
Managing MG during pregnancy is indeed a delicate balance, as most women with MG of childbearing age require immunosuppressive drugs, which carry their own considerations. There is an increased risk of MG worsening during pregnancy, with the first trimester and the month postpartum identified as periods of highest exacerbation risk. This necessitates close monitoring. Pre-pregnancy planning is crucial. For women contemplating pregnancy, thymectomy should ideally be performed beforehand. As studies have shown, it can reduce the risk of neonatal MG in the child.
What about medication safety during conception, pregnancy, and breastfeeding? This is crucial for intensivists and obstetricians collaborating. Can you break down which drugs are generally safe, those to use with caution, and those to avoid entirely?
This is a complex but vital area. Generally safe. Pyridostigmine. Considered safe during conception, pregnancy, and breastfeeding. Dose adjustments may be needed for changes in absorption or increased emesis during pregnancy. Corticosteroids. Generally considered safe during conception, pregnancy, and breastfeeding, particularly daily doses below 20 milligrams of prednisone or prednisolone. However, close monitoring for gestational diabetes and preeclampsia is still important. As azathioprine and considered safe during conception, pregnancy, and breastfeeding. It's a commonly used steroid-sparing agent in pregnant MG patients, IVG, and plasma exchange. These are deemed safe and highly effective rescue therapies during pregnancy and in the postpartum period for acute exacerbations or crisis, as they do not cross the placenta significantly or cause fetal harm. Caution or avoid rituximab. If possible, it should be discontinued at least 3 months before pregnancy or from conception due to potential impact on fetal B-cell development. However, it can be used from 2 weeks after birth, with breastfeeding generally allowed 6 hours after infusion, as monoclonal antibody transfer into breast milk is low and peaks within 48 hours. Mycophenolate, mofetil, methotrexate, and cyclophosphamide. These are absolutely contraindicated and should not be used in women of childbearing age or during breastfeeding due to their moderate to high risk of severe fetal harm. Teratogenicity. Reliable contraception is essential for any woman on these drugs, tacrolimus and cyclosporine. These calcineurin inhibitors are generally regarded as having very low or no increased risk during pregnancy, but they should always be used at the lowest effective dose necessary to control MG symptoms, with careful monitoring of maternal and fetal well-being. Complement inhibitors, for example, eculizumab, revelizumab, zilucoplan, and FcRn blockers, example epgartigimod, rosenelixizumab. Currently, there are limited data to support their safety in pregnancy, and thus they are generally not recommended unless absolutely necessary in severe refractory cases and with extensive patient counseling.
So the newer biologics are mostly off the table for pregnancy right now.
Generally, yes, due to lack of data. However, it's worth noting an interesting theoretical point. FcRn blockers inhibit IgG transport from mother to child. This property may make them a potential treatment alternative during the first 2 trimesters to theoretically avoid fetal AChR inactivation syndrome and arthrogryposis in the child, although this is still investigational.
What are the specific considerations for delivery and immediate postpartum care for a mother with MG? This is crucial for the intensivist in a labor and delivery setting.
Women with MG should ideally give birth in hospitals equipped with a neonatal intensive care unit, an ICU, as there is a small risk of transient neonatal MG in the infant due to transplacental transfer of maternal antibodies. Vaginal delivery is generally recommended unless there are specific obstetric indications for a cesarean section. Epidural analgesia is the preferred method for pain relief during labor, as it avoids systemic respiratory depressants. Crucially, for intensivists, magnesium should be absolutely avoided as a treatment for preeclampsia and eclampsia in MG patients, as it has a direct neuromuscular blocking effect and can significantly exacerbate MG, potentially precipitating a crisis. Finally, immunosuppressive drugs should be promptly restarted postpartum if they were stopped before or during pregnancy due to the increased risk of MG exacerbation in the immediate postpartum period. Routine vaccinations, as per standard programs, should also be reviewed and updated.
Let's discuss physical activity and rehabilitation. Historically, there was a fear of overuse muscle damage in MG patients, leading to recommendations for rest. Has that understanding changed?
Yes, the understanding has significantly evolved, and it's a very positive change for patients. Historically, there was indeed a fear of overuse muscle damage and worsening weakness in MG patients, leading to recommendations for limiting physical activity. However, contemporary studies now confirm that physical activity is safe and beneficial for most patients with stable MG. It's no longer something to shy away from, but rather to encourage appropriately.
What are the specific benefits of exercise, and what are the current recommendations for stable MG patients?
Training and exercise can significantly improve muscle strength, functional outcomes, and overall well-being. For stable MG patients, current recommendations are generally in line with general health guidelines. At least 150 minutes per week of moderate intensity physical activity is recommended. Interestingly, studies show that MG patients are often less active than controls and frequently do not meet WHO recommendations for physical activity, likely due to historical advice or fear of exacerbation.
So individualized programs are key to successful rehabilitation.
Absolutely. Patients benefit greatly from individualized exercise programs supervised by a physiotherapist or within a structured gym setting. These programs can improve aerobic capacity, muscle strength, and balance, tailoring activity to the patient's specific level of weakness and fatigability. There's also an association between moderate or high levels of physical activity and lower levels of fatigue, though some studies have found no improvement in fatigue after exercise programs, indicating fatigue is a complex symptom beyond just muscle weakness. It's also critical to caution that heavy physical activity and intense training should be strictly avoided in patients experiencing an MG crisis or those at significant risk of developing one, as this could precipitate or worsen respiratory failure.
Finally, let's consider rehabilitation for work and life balance. How does myasthenia gravis impact daily life, especially work? And what can we as healthcare providers do to support their functional recovery and reintegration?
MG patients often need to ration their daily activities, which can significantly impact their ability to hold full-time jobs, perform tasks at home, and participate in standard social activities. This profound impact on quality of life is critical. A Danish study, for instance, found that MG patients had almost 6 times higher odds of no labor market participation and long sick leave 2 years after diagnosis compared to the general population. An Australian study reported that a striking 40% of MG patients had stopped working and 20% had changed their occupation due to MG, highlighting the socioeconomic burden.
That's a huge impact on people's lives and ability to work.
Indeed. We recommend that rehabilitation takes place within a coordinated, multi-professional network, including neurologists, physiotherapists, occupational therapists, speech therapists, and psychologists. Healthcare professionals must be acutely aware of and actively address the challenge of finding the right work-life balance from an early stage and continuously throughout the patient's life, as MG is a chronic condition with fluctuating symptoms. Work adaptations are often necessary due to physical impairment, chronic fatigue, and potential treatment side effects. Psychological intervention, including cognitive behavioral therapy for fatigue management and peer support groups, can significantly increase function and coping, and psychological support or referral to an experienced psychologist should always be offered. Providing information about relevant patient advocacy groups is also invaluable, as such groups can offer a community, shared experiences, and practical coping strategies.
Okay, let's consolidate the key takeaways from our deep dive into advanced therapies and holistic care. We've reviewed the array of new biologics, including the FcRn inhibitors like efgartigimod and rosnilimab, and the complement inhibitors like ravulizumab, zilucoplan, and eculizumab. We highlighted their specific mechanisms, their rapid onset of action, and critical safety points like the absolute necessity of meningococcal prophylaxis for complement inhibitors. We then discussed the precise indications for thymectomy, crucial for thymoma and non-thymomatous AChR-EB-MG, but explicitly not for MuSK-positive disease. Finally, we delved into the nuanced management of MG in pregnancy, covering medication safety, emphasizing the avoidance of magnesium during delivery, and the safety and benefits of physical activity and multi-professional rehabilitation for long-term quality of life. Here's a thought-provoking question for you. How might the unique property of zilucoplan specifically, its being a peptide unaffected by Ig recycling pathways, allow for novel combination therapies in myasthenia gravis management? And what's the potential significance of such combinations for the future of treatment?
This is truly exciting and points to a new era of targeted therapies. Zilucoplan's unique property as a peptide means its action in inhibiting complement C5 is completely independent of the IgG recycling pathway mediated by FcRn. This implies that it is not influenced by FcRn inhibitors, a distinct class of biologics that work by removing pathogenic IgG autoantibodies. This opens up the compelling potential for synergistic approaches where zilucoplan, by directly targeting and inhibiting the terminal complement cascade, could be safely and effectively combined with an FcRn inhibitor that targets the removal of pathogenic IgG autoantibodies. The significance is profound. Such combinations might achieve a more comprehensive, rapid, and profound suppression of the autoimmune attack from multiple angles, potentially leading to faster, more robust, and sustained clinical improvements, especially in patients with severe or otherwise refractory MG, truly offering a multi-pronged attack on the disease mechanism.
Fantastic. Now for our comprehensive mega recap, or as we like to call it, your flashcard summary. These are the high-yield points you can carry forward from this deep dive.
All right, let's hit the key points. Core definition: MG, autoimmune, fluctuating weakness, antibody attack at NMJ, mostly AChR. Most common NMJ disorder. Key symptoms: ocular, plycosis, ophthalmoparesis, orbicularis oculi weakness, bulbar, dysphagia, dysarthria, chewing fatigue, high aspiration risk. Limb, proximal, fatigable. Respiratory potential for rapid failure. Remember, pupils always spared. Antibody subtypes. AChR most common. MuSK means more bulbar issues, higher crisis risk. NO thymectomy benefit. Seronegative exists, especially ocular. Crisis triggers. Infection, biggest one. Surgery, pregnancy, meds, tapering immunotherapy, sometimes spontaneous. Crisis management. First line, NMV day or PILA-X. Used with steroids often, helps bridge the steroid dip. ICU setting crucial. Anesthesia pearls. Avoid NMBAs if possible. If needed, use Sugammadex for non-depolarizers, rocuronium, vicuronium. Quantitative TOF monitoring is essential. MG resistant to depolarizing, succinylcholine, sensitive to non-depolarizing. LEMS, sensitive to both. Drugs to avoid caution. Respiratory depressants, opioids, benzos. Aminoglycosides, fluoroquinolones, macrolides, beta blockers, proclaimide, quinidine, Botox, chloroquine, statins, immune checkpoint inhibitors, contrast, penicillamine, quinine. Crucially, magnesium avoid, chronic immunotherapy. GCs, steroids, first line. Start low, go slow. Gradual escalation to avoid steroid dip. Taper carefully. Monitor bone, sugar, eyes, mood. Consider PJP prophylaxis. Conventional IS, as is azathioprine, must check TPMT first. Mycophenolate, teratogenic, cyclosporine, tacrolimus. Delayed onset months, steroids sparing. Biologics new era. FcRn inhibitors, efgartigimod, rozanolixizumab. Boost IgG breakdown. Complement inhibitors, ravulizumab, zilucoplan, eculizumab, block MSC. Rapid onset, often steroid sparing. Meningococcal vaccine mandatory for complement inhibitors. Thymectomy for thymoma, do it early. Non-thymomatous AChR plus MG, 50 to 65 years, not for MuSK plus Widesep. Pregnancy lactation, pyridostigmine, low-dose GCs, azathioprine, IV GPLX generally okay. Avoid mycophenolate, methotrexate, cyclophosphamide. Caution with rituximab. Avoid magnesium at delivery. Holistic care. Physical activity is safe and beneficial. 150 mink moderate. Multi-professional rehab, PT, OT, psych, peer support, vital for QOL. Fatigue, work.
You've just taken a deep dive into the complex and often challenging world of myasthenia gravis, a condition that truly embodies the intricate dance of personalized medicine in critical care. We've covered everything from its nuanced clinical presentations and the subtle signs of impending crisis to the cutting edge of immunotherapy and the intricate balance required in perioperative management.
As intensivists, you are often at the front lines, managing the most acute and life-threatening exacerbations of MG. Your understanding of those subtle signs of impending respiratory failure, the delicate balance of medications, and the crucial role of rapid immunotherapies can quite literally be the difference between life and death for these patients.
So, as new therapies emerge, many with significant financial burdens, how will the healthcare system balance the promise of revolutionary treatments with equitable access, especially given that many patients are diagnosed in the prime of their working lives? And how might your role as an intensivist evolve from solely managing acute crises to participating more actively in the long-term, holistic care trajectory, advocating for your patient's quality of life and functional recovery far beyond discharge from your ICU?
It's a profound question, pushing us to consider not just immediate survival, but sustained well-being and integration into daily life. Yeah.
Food for thought indeed. That's all for this deep dive.